Welcome to this healthcare session. Due to the last changes of COVID, we cannot sit together in a studio, but we are glad to be here and share with you this moment. Some practical information before we start. This session will be recorded and will be available on our website afterwards. Do not hesitate to use the chat box to interact with us, to ask any questions you have on the different subject we will treat today. And please ask your question using the question tab. We will answer them live at the end of the session. Today I would like to welcome Thomas De Rijdt, Head of Pharmacy at UZ Leuven, and Dirk van der Wouwen, Serialization Director, EMEA, Deployment Lead, Digital Identification and Traceability, Janssen Johnson family of companies. Thank you both for being here for this panel discussion. For GS1, it is important to work together with all stakeholders to achieve our goal of an efficient supply chain and enhance patient safety. It is key to have the right product in the right place at the right moment for the right patient to ensure their safety and to have detailed traceability information. It all starts with the beep, as you have seen in the end. It all starts and ends with the beep, as you have seen in the introduction video. Let's now have a look at a short animation which shows the use of our global GS1 standards throughout the entire process, from the manufacturer to the distributor, to the hospital, and finally with the patient. Let's start the video. And some small issues with the video. I hope it will start in a few minutes. They're saying they're working on it. We have to go without the video, and bring the video later on. Okay, I think we will go without the video for the moment. They will solve that technical issue afterwards, and I hope to come later and show you the video to introduction. So yeah, you will miss then all the introduction about our standards that are shown in this video. But the most important part is, in fact, when you see the identification of a product through our global trade item number. That is one of the most important parts for traceability, together with the lot number, the best before, and the serialization number for prescribed medications or implants. I will start and ask a question for Dirk to start with. Dirk, can you outline which are the industry's point of view on the benefits of our global standards, or GS1 standards?
Yeah, thank you, Patrick. First, I want to thank you for the opportunity to be here. And secondly, when I saw that movie, the introduction movie, I think we may not forget why we are here. We're all talking technical stuff, but in the end, we are there for the patient, to secure the patient and to be more accurate and efficient, let's say, in providing the patient needs. So about standards, I would like to start with a little bit of history. So nobody will deny that standards are and have been crucial to humanity. Communication has been possible since the dawn of man through the use of language, which is nothing else than a standard of communication. Initially, it was organically grown. Later, it was set in formally agreed standards, like vocabulary and grammar. Other standards we daily deal with are standards that enable trading, measuring, and so on. The more global our society has evolved, the more global we realize that standards need to be agreed internationally. So the euro as a means of payment, international trade agreements, traffic signs across Europe, standard product labeling and packaging, just to name a few. So industry these days typically operates globally. And as a result, internationally agreed standards are indispensable to do business. They are required to be able to communicate efficiently with both internal and external partners and to operate the supply chain end-to-end in an efficient way. So the digitization of doing business also urged the need for standards. Standards make it possible to work with global products. It is a means to realize automation in internationally operating factories and warehouses. Costs remain under control. The risk of human error is minimized, and that is a very crucial point. Repacking and rework is minimized. Speed to market flexibility is increased, and interoperability is facilitated. Additionally, working with standards has enabled sharing information with authorities in a standard way, mentioning the MDR or the Falsified Medicines Directive. Information is required to ensure traceability or verification of products, for instance, to fight counterfeit, but it also allows sharing trusted data of products in an agreed way with regulatory instances and also with our customers. As it is the standard used across the globe, GS1 is the language used to make this possible. Products are uniquely identified with a GTIN, the global standard used worldwide for product identification. So automatic errorless product authentication and verification is made possible for all partners that handle the product. This is done by coding by means of standards in a linear barcode or in a 2D matrix. That code can include other information as required by the supply chain or the health authority. So we can include batch number, lot number, expiry date, serial number, manufacturing date, or even software number for software applications. As a result, events on products can be captured via scanners to support the business processes at production, at shipment, at receipt, from manufacturing till end customer. This enables true traceability, as I already mentioned, at product level, batch, and even pack level when we serialize products. It also provides means to verify authenticity of product, check expiry date, for instance, and it could even facilitate recalls at product level. At the same time, the GS1 standard for information exchange can be used to exchange details of production, shipment, from sender to receiver using the EPCIS standards, and as such enable end-to-end traceability as well by sharing the information about the products and the shipments. For transactional purposes such as order management and invoicing, the EDI standard is also commonly used. So in principle, this makes manual transactions in system unnecessary. Movement of goods and related information management is made easier, faster, and errorless. This ultimately benefits the customer, and in our case, the healthcare provider and the patient. Total cost of ownership remains manageable. Interoperability can be ensured within and across partners in the supply chain. So when we then look at the operating room, traceability becomes key. Hospitals need to register which implants, devices have been used, and using barcode technology make this efficient and errorless. So it is key to identify all medical devices with a standard identification for which we at J&J use GS1, not only product code, so the GTIN, but also, for example, lot information can be very crucial and required. In addition to exchange of information with customer or distributors, the GS1 standards also support exchange of information with regulatory systems, as I mentioned. So also for the future, I see opportunities, for instance, with the FMD and recent pandemic issues. There were shortages in the supply chain for some of the pharmaceutical products. And with FMD, you can trace basically how much is still in the supply chain, what is produced and what is not yet consumed at the pharmacy level or at the hospital level. So you could, or the national competent authorities could have a visibility on what is still available, how much is available in Europe to provide to the patient. And based on that, they could take action, informed action. There are also challenges, of course, with everything we do and all innovation and digitization. As an industry, we are operating in a global context, as I mentioned. And although there are standards available, the way how to implement it can differ between different stakeholders or between different countries. So in Europe, just to give an example, we have countries that stick to the national numbers to be encoded as a product identification. Some countries require extra information to be included in the 2D matrix, and this makes it not easier, let's say, for the manufacturers. It avoids that we work with global products or with multi-country products. It puts also extra challenges on the technology in the factories. So to ensure flexibility in supply and avoid product obsolescence, there's a big benefit of using these multi-country packs. And this is only possible when the different national competent authorities are aligning their requirements. A good example of this, I mean, is the COVID vaccine, where recently the EMA has approved that we work with one global cheating and one, let's say, 2D matrix on the pack. This has a result. As a result, we have produced products that could be supplied to any market. And you can imagine in the pandemic situation where the demand was fluctuating tremendously, and where also the supply was somehow could be sometimes very constrained. This has provided a lot of opportunities and flexibility in the supply. For medical devices, the challenge of this multi-country pack concept are even bigger than for pharma products. There's much more variety in products in medical devices. Every size, every different specification requires another product identification. And as a result, most medical devices are managed through global products over the globe even. So any deviation from the standard may cause disruption in the supply chain. So it may require then customization for a specific country, which we typically do then late stage customization, but it's extra cost, it's repacking, and it creates extra lead time and less flexibility to the patient. So that's again, the biggest challenge I think is alignment with the stakeholders, both at national, international level. And yeah, that is a challenge for the future.
Okay. Yeah. Thank you, Dirk. So that's clearly an advantage to use the GS1 global standards. But Thomas, how do you see that from an hospital point of view? And given, of course, the legal obligation you have imposed by Europe, but also by Belgium?
Okay. Thank you, Patrick, for the invitation to participate in this panel discussion and to giving us the opportunity to show what we do in our hospital. And I think Dirk has just given a comprehensive overview of what the GS1 standards are used for in the pharmaceutical industry and medical device industry. And when I take a look at the following part of the supply chain, there's definitely a role to play in the hospitals for the GS1 standards. And maybe I'm a bit biased, as UZ Leuven has bedside scanning for all medication in place since nearly 10 years and is deploying a similar application to trace medical devices at this moment. But I'm sure that many hospitals in Belgium will follow, as the recent royal decree of 13th of September 2020 makes unidose dispensing and traceability mandatory in the Belgian hospitals. And besides this, for medication and medical devices, it was also an obligation to trace implants through the legislation regarding the central traceability register just mentioned by Dirk, and also the MDR mentioned previously. But let me start from the pharmacist DNA. We're a very special kind, and we are trained to provide qualitative pharmaceutical care and to guarantee conformity of the products we dispense, medication, medical devices, but also with a very high focus on patient safety. And when you take a look in literature and you look after medication errors, you see that they find in most cases their origin in a wrong prescription or transcription, and in a wrong administration of the drug to the patient or to the wrong patient. It's not that much the pharmaceutical process, the dispensing process where it goes wrong, but mostly in the CPO, in the prescribing, and therefore most of the hospital introduced the CPOE or an electronic prescribing system. And more, they are working all on clinical decision support to guide the physicians, the prescribers towards the best prescription, the best therapy for the patient. And even now, as we speak, hospital pharmacists are obliged by the new legislation to do a clinical validation, a review of all the prescriptions made by the physicians in the hospital before dispensing. So to prevent administration errors, we introduced in our hospital bedside scanning, as this was the second biggest origin or source of potential medication errors. And here we scan the patient and the drug, and this combination of data is compared with the actual prescription, resulting for the nurse in a traffic light system where green means you can administer the drug, red means this is something wrong, and orange, for instance, you get the right drug but a different brand name, or you have to give half a tablet or 2 tablets, so orange light to focus on extra actions to be taken by the nurse before administering the drug. And in this way, we reduced the number of medication errors significantly. We did some studies on that, but we also improved our pharmaceutical and medical dossier as well, the keeping of inventory and the billing process to the patient and to the authorities. So you can understand that in this approach, it is essential that every pill or any other medication has a scannable unique identifier. And as production of single-dose barcoded medication is quite costly, I know because we do it ourselves for the products that are not coming directly single-dose barcoded from industry. And I also know what it costs to change a line, a production line in industry, so it's not that simple. And therefore, I understand that industry wants to work with a code as mentioned by Dirk that is scannable in multiple countries, and for the same reasons, hospitals and especially IT services want to work with only one standard, one application, one database to link with, because if you have to maintain 50 links, 50 applications, that's not feasible and not cost effective. Maybe an anecdote in the past we had when we started with bedside scanning and GS1 was not all overall in place in most of the companies. We had companies working with random codes. Some of them were using the national code of the drug, some were using an own code. And at a certain moment in time, we had 2 drugs in the pharmacy which had apparently by some coincidence the same number. These manufacturers had applied the same random number. I don't have to explain that this would have led to errors, and therefore I'm very happy that we see that most of the companies are now using a GS1 standard with a GS code which guarantees that we have no double codes available in the hospital. So we made a statement with our professional organization, the Belgian one, but also the European one, that we wanted at least GS1 code as an identifier on the single pack, not on the commercial available pack, but on the single pill, the level below the each, as was it called by GS1 in previous times. So we could identify the drug to see whether the right drug comes to the right patient, because most of the errors were related to wrong drug, wrong patient, not to a past expiry date, a different batch number. And I know that adding a GT number as fixed data is more easy than adding variable data on the single pill. But with the new legislation where the hospital pharmacist is obliged to do a full traceability end-to-end of everything that goes into the patient, whether it's a drug, preparation, compounding, or medical device, I think that this variable data becomes more interesting and should be added. And even for implants, beside the GTIN, a batch number and an expiry date, we can add a serial number for implants, but also I think there is a way to go for IMPs, so the drugs used in clinical trials, where we maybe can add a serial number to the specific drug, as this is used in blinded clinical trials. But as mentioned by Dirk, it's not only medication that has to be traced in the patient, also medical devices, implants must be registered. And Dirk mentioned already that it is a far broader gamut to control, and with a uniform code in this case isn't a luxury, because for Belgian drugs, we only talk about the Belgian market, but let's say 90% of my new article numbers, my new items in the pharmacy are not concerning medication, but are concerning medical devices. So a much broader group to control. So with the introduction of UDI in the hospitals, the hospital pharmacist has everything to guarantee this end-to-end traceability we would have in the hospital. And we also have a tool to improve the supply chain process in our hospital, as we can use the barcode not only for registering the implantation in a patient, but also to control the supply chain in the hospital. So for this in UZ Leuven, we are deploying right now a KWS module. KWS is our hospital information system, where everything that concerns the patient is registered in one system. So we have made a module we are deploying right now that allows to scan all medical devices that are used in the operating theater, and an extension on all the services using implants, medical devices, invasive medical devices. And on the contrary, as with bedside scanning, where we scan the patient for every drug, we link an operating theater to a specific patient, as long as the surgery is going on, and whatever is held before the scanner and scanned is linked to the patient, and afterwards validated by the physician or the surgeon as a prescription, allowing us to feed the register of traceability, to comply with the regulations, but also to control our inventory when we have consignation stock, to steer all the new purchase orders. So I think this is a better system when everything has a UDI code printed on it, as what some hospitals were doing for years right now. What is relabeling when the medication or medical devices enter the hospital. It's not only time consuming, but when you work with consignation stocks or with loan sets, it's even not possible to add your own labels to the medication or the materials that are owned by the different companies. So I think besides what we mentioned about UDI, GTIN can be used as a key to link to other databases. And then I'm thinking about, for starters, the hospital database, the one we have on our own, but also the source authentic for medication, the SAM database, which is the government is using, the RECIF databases, but also a product database where we can have product information, such as the ECHO project from GS1, maybe a link to patient leaflets, educational videos for patients, and in the future, maybe for ambulatory care, even an app to measure patient compliance with therapy based on the patient scanning his drug when taking the pill or the medication. Dirk mentioned already FMD, Falsified Medicines Directive, and I think with the introduction of this, GS1 standard were introduced in the hospitals, and hospitals have BITE scanners that can read GS1 codes. And although that Belgian hospitals are not at a great risk for counterfeit medication, because of we are buying from Belgian wholesalers, Belgian manufacturers, I think this system prevents harmful situations on a European level. But not only the safety is an issue. Once we have aggregated codes, which we are working on with different companies right now, and we can integrate this in the repositories from BEMVO and EMVO, we can free up some labor time, but also make tasks more ergonomically. For instance, when we have pallets of huge IV drugs, which have to be unloaded and scanned before they get loaded again and dispensed to the hospital, I think that aggregated codes, of course, with a guarantee that there's no risk, based on a trusted relation, we can free up some time and make tasks more ergonomically in the hospital. There's also, in my opinion, with the introduction of barcoded medication, an impact on the buying process. For medication, a single dose barcoded package becomes an asset in public tendering. For implants, we have seen already a shift from multi-pack non-sterile products to single-packed sterile devices, which has an impact on storage as well. But besides the positive effects, we still see some hurdles to be taken in the hospital. For instance, when you have a drug with an active ingredient and a solvent in one pack, do they have to have both a cheating code, which one to scan in our system? But also for devices, some devices come still in multi-packs. You have a pack of 5, but you only implant 2 of them. How do you identify this? Also, when you do a re-sterilization or a reprocessing in hospital for instance, screws, orthopedic materials, how can you identify them in this in-house production cycle? But also items that are maybe too small in orthopedics to put a barcode on. When you put it on the package, it's taking a lot of storage area. So I think although we have a great benefit of this standards, we still have to discuss how we work out these small problems we still encounter. Product identification is best known by the hospital pharmacist, but I think that also other GS1 codes, besides the one mentioned like cheat-in, can be useful and cost-effective in hospitals. Some hospitals are, for instance, already using locator codes when they work with your EDI system to exchange purchase orders, invoices, and kind of things. But maybe in the future we can also use a patient identification number, so we can make this hospital independent by using GS1 codes instead of hospital-owned codes, so we can avoid possible errors in the future when patients has a bracelet from a previous hospital, for instance, when there is a transfer. So I think we have full of opportunity in the hospitals to work with GS1 standard, such as one standard, but I'm also think that we as a sector have still a way to go and to improve our patient care.
Okay, yeah. Thank you, Thomas. I was just informed that the technical issue we had with our video is solved. So I hope we can start now the video first. This is not the right one. Thank you. It is the other one, please.
GS1 Standards pave the way to patient safety and efficiency. When you think about a hospital, you think about doctors, nurses, patients, the medical department's administration, and external service providers. All of them are involved in patient care. To run optimally, purchasing and logistics should fit together and run smoothly. Patient safety and traceability in the whole chain should be guaranteed. GS1 Standards makes this possible. From manufacturers to hospitals and patients via logistics service providers, optimizing the supply chain is a clear plus point for everyone. GS1 standards are easy to integrate globally and interoperable. This creates the basis for higher patient safety, security of supply, and process efficiency. It all starts with the unique identification of the products in a global trade item number, GTIN. Depending on the products, the GTINs are encoded in a GS1 data matrix, an RFID, or a GS1 linear barcode. The GTIN can be extended with data as expiration date, batch number, and serial number. This is called a unique device identification for medical devices. The MDR regulation also asks for a basic UDI-DI, which identifies the product model or the product family. GS1 standards are fully compliant with different regulations, such as the European MDR regulation for medical devices and the FMD regulation in Europe for pharmaceutical products on prescription, or any other product used in the healthcare sector. Usage of GS1 standards goes beyond the identification. For each GTIN, product information, such as the size or the material of a product, can also be exchanged through the value chain. The product data is provided by the manufacturer through My Product Manager or GS1 Global Data Synchronization Network, and is available for the whole supply chain. Let's have a look at the route followed by a medical device and the associated GS1 standards, from the manufacturing site to the patient in the hospital. It all starts at the headquarters of the manufacturer, which is identified by a Global Location Number, GLN. At the manufacturing site, products are uniquely identified with a Global Trade Item Number, or GTIN. Each pack, case, and secondary packaging is also identified with its own GTIN, allowing everyone to know how many products are contained in a box. Serial Shipping Container Codes, or SSCCs, are used to track contents of shipments leaving the manufacturing site. This provides the foundation for patient safety, product traceability, and recalls, and facilitates accurate tracking of inventory. In the distribution center, also identified by its own GLN, GTINs with extended data, such as lot number and expiration date, are used to put products in inventory and ensure accuracy of picked products. SSCCs are used for each pallet shipped and used to track shipping units. In hospitals, GTINs and their extended data, together with the SSCCs, are used to validate delivery accuracy. GTINs and internal hospital GLNs are used to put products in inventory. Using GTINs and GLNs improves internal distribution processes, reduces accounting costs, and maintains chain of custody through automated processes. GS1 identification numbers not only identify products and locations, but they can also identify people, such as doctors, nurses, and patients, with a Global Service Relation Number, or GSRN, and assets, such as a bed, with a Global Individual Asset Identifier, or GIAI. Information is encoded in the patient's wristband. By scanning the barcode, the doctors and nurses are able to verify that the right patient receives the right product that has been electronically prescribed at the right time, before a treatment or drug is given. Products used in the operating room during the procedure are documented on their patient chart by their GTIN and extended data. Data is shared across the hospital information system, and all GTIN and extended data is tracked from the point of order to the patient, allowing for a final check. This is key for the efficiency of the supply chain and the safety of the patient. GS1 standards are also used for electronic data interchange, or EDI. GTIN and GLN information are synchronized to improve order, inventory, and invoice accuracy. Using GS1 standards offers many advantages. It enables digitalization of the processes, reduces administrative work and errors, saves time and costs, and ultimately increases patient safety. Don't hesitate to visit our website for more information.
Okay, this was then our introduction video we wanted to use. In fact, our global GS1 standards are composed of three parts. There is the first part is identification of the product. Then there is the part of the capturing of the product, and the third part is, of course, the sharing of the data. And the most important part, or one of the most important part of the exchanging data, is the exchange of trusted data through the Global Data Synchronization Network, or GDSN. For that, in Belgium, we use My Product Manager as a front end. It is a cloud-based system which is easy to use and, of course, connected to the GDSN network. It is the manufacturer or the importer's responsibility to provide this trusted data, and GS1 can help to make it available in a standard way. And we have spoken about the ECHO model to the hospitals and other players. Today, we are dealing with different databases managed by different players, both public and private. The data must be up to date, correct, and complete. But all those databases use some different keys. And so there is a different problem of interoperability between those databases. And we have, for example, for everything what is medical device, we have the notification number. For drugs, we have the C&K number, just as an example. Today in Belgium, in the healthcare sector in Belgium, we are a little bit in the chicken and the egg situation regarding GDSN. What came first, the chicken or the egg? This was the case a few years ago in the DIY or pet sector, but today it's used by most of the key players. If you look at the healthcare sector in the Netherlands, it is already widely used, spread between the hospitals and the manufacturers in the Netherlands. But let me ask a question to Dirk. What challenges do you see to exchange this data with our Belgium and Luxembourg hospital in order to, as mentioned in our forum last month, stop sending Excel sheets for exchanging data and ad hoc requests to have it exchanged of data?
Yeah, Patrick, let me first talk about the opportunities, because I see a lot of opportunities in a regulation in the Netherlands that require the healthcare professional to record implant data in the file of the patient. The healthcare professional also must provide data regarding this implant in writing to the patient, and finally he needs to register the implant data in the landelijke implantatenregister. So to enable the healthcare professional to comply with these requirements, the manufacturer must first identify the device uniquely with the use of a cheat in a 2D matrix or a linear barcode. But secondly, more importantly, he also needs to share a large number of product data with the landelijke implantatenregister and with the hospitals. And this is made possible by using the cheating, as I mentioned, in the UDI, but also by using the GDSN approach through the use of GS1 certified data pools. So we are exchanging a standard set of data with the hospitals in Netherlands. This was a way to integrate in a smooth way trusted data from manufacturers to the regulatory instances and the hospitals. This approach also ensured that only certified products are being used. And as I understand from my colleagues in the Dutch market, it allowed to drastically reduce also the multitude of ad hoc questions from hospitals and from other key stakeholders about products and about product data. Now these data are in one set of trusted data made available to the different stakeholders. The use of the standardized system, GDSN, also ensures that we no longer have to mess around with Excels and set up manual extractions or semi-manual connections with hospitals. What is also an immense advantage of the GDSN process is that the data can be shared with different partners through one system. So it's partners connect through a global location number with the database. So we can set, okay, this partner with this GLN can receive these data. And this is, let's say, also as a result, the data we maintain in our data lake can be shared, for instance, with my product managers for sharing trusted data in Belgium with the hospitals and with Luxembourg. To maintain GS1 standard as an international standard and minimizing customization for specific country is a challenge. So to answer to your question, the opportunity is to deliver that what is essential for all hospitals, but limit to the essential. So we should not go in the route of tailoring the data to the requirements of each individual hospital. You can imagine that this is already a challenge at a national level, but you can imagine then at international level, this also becomes a challenge and a burden. And in the end, there is a risk that it creates an unnecessary and unmanageable complexity for the supplier. So alignment is necessary, not only at national, but also at international level. And in addition, we also see that there is a tendency to include, besides supply chain data, more regulatory data via GDSN. This brings a new aspect to the use of GDSN, as it now becomes a data flow that falls under regulatory compliance rules. And as a consequence, it is subject to a different level of validation rule within, let's say, the company, but also within the systems we use. We must be mindful of this and go step by step. So to conclude, I mean, positive, the tool, GDSN tool, is a good tool. It allows to share data. It allows also to share same data with different partners, even across different nationalities, across different nations. But I would firstly plea for less is more. Let's focus on the essential first and strictly necessary, in consensus with industry and hospitals and procurement organization. Secondly, Rome wasn't built in a day. I mean, this is a trajectory, it's a journey. Let's not rush about it. It's about data quality and accuracy. And in the end, it's mainly there for the patient. So we should do the right job, the good job in an accurate way. So let's not rush, but go step by step.
Okay, thank you, Dirk. You've put it very clearly. So there is really a need to have a cooperation between all partners needed for this data. Just as an example, last month I had a call with Thomas' team from UZ Leuven in the on the context of implementing the API. That is the interface we use to connect, that UZ Leuven will use to connect to my product manager, we then connected to the GDSN network. That was clear that we need a real further collaboration between suppliers and the hospital to understand what is the need of the hospital, but on the other hand also to understand the need of the supplier. Thomas, can you tell us what are the challenges from your point of view for hospital today in the content of changing master data, and how can GS1 help or facilitate you with that process?
Okay, I think I can start with saying that the paper era, which we have known in the hospital for decennia, comes to an end. And we see robotization, digitalization, automation in many processes in the hospital and also in the hospital pharmacy, as it is less error prone, but also more cost effective. And with the introduction of local regional networks, centralization of services, I think this will be even more in the future. But also data exchange, when we talk about a new article number in the hospital, whether it's a drug, whether it's an implant medical device, the creation of an item number in our pharmacy database requires us about 300 data fields to enter, from financial data to clinical data to whatever, storage data, inventory data. So it's a lot of work, and you can imagine the waste of time when you know that every hospital is doing the same job for the same things, and then even not to mention the risk on typing errors and the number of typing errors we can encounter in this operation. So I think data exchange may become the new gold in our sector. When we can link to trusted data in authentic sources, or when we can exchange catalogs, product specification, price lists, and then there's an issue, of course, with the net price per hospital based on a tender versus the list price, but something we can solve. But also product photos to help physicians to identify drugs, medical devices, to help logistics. I can think we can save a lot of time and avoid a lot of errors in our databases and improve our processes. So, but also the exchange of purchase orders, as mentioned with the EDI, the shipping notes, the invoices, can facilitate administrative processes in the hospital and not only in the pharmacy. For instance, we have seen that working with digitalized invoices, we can reduce the number of full-time equivalents in the financial service who is dealing with all these paper invoices in the past. And therefore, UZ Leuven also invested in digital data exchange with our distributors. And soon it became clear that you need one uniform system. As mentioned, it's not cost effective to maintain multiple systems. And I think this should be a uniform system all over the sector, and not in Belgium, but all over Europe. And as mentioned by Patrick, we are effectively exploring this API. And I think that as a big hospital, we have to work with the API, where it is system-to-system communication, better than one human has to work on a specific web application, that we need such a thing. And therefore we are cooperating with GS1, and the pilot we are setting up right now looks very promising to me.
Okay, thank you both for your input. And before we go and move to the Q&A part, how do you see the evolution and the future? Dirk, can you start with how you see the future?
Yeah, I think a lot will change in the future, not only in Belgium, but worldwide. We've seen initiatives that will lead to further digitization in the supply chain. In the healthcare, this digitization is and will be driven by new legislation and customer requirements. In addition, manufacturers see still many opportunities to organize the end-to-end supply chain in a more efficient way and to work in a more customer-focused way through digitization. It's a trajectory. It shall be a win-win for all players. Talking about e-leaflet, RFID, real-time product verification, up until the patient to ensure adherence to prescription, for instance. We need to be aware that it will require sustained dialogue between all stakeholders, including authorities. It will be important to listen to each other's needs and limitations and try to understand and then be creative in working out new solutions.
Okay. Thomas, how do you see that for you?
Oh, mostly I agree with Dirk. I think hospital pharmacy is changing. When I take a look at a pharmacy 5 years ago, it's not the same as the pharmacy today, and it's definitely not the same as the pharmacy will be within 5 years. And it's not only legislation, but also expectations from our patients, authorities, the community even. There are strong drivers to digitize and to automate our processes. And also the introduction of local regional networks, as I mentioned earlier, will lead us to centralization, upscaling to get the benefit of the scale, and thus also for data sharing as we will work from different locations. So it looks that we are evolving towards a new digital world, but in fact, we are lagging behind. When I take a look at the retail sector, when I go to the supermarket or to the do-it-yourself stores, they have implemented this. They can do what we are working on right now, and it's hard to understand as a healthcare professional that healthcare is data to talk about risks and patient safety, where in the other sector you talk mostly about financials. So maybe as mentioned by Patrick, it is the chicken or the egg story, and we were waiting for each other. We were waiting for industry waiting for the sector. We were all waiting for the government to take actions. And I think it's a good thing that UDI, FMD, Central Traceability Register, legislation on traceability in Belgium woke us, and that we have to catch up with the other sectors by now. So personally, I think that it's very important that healthcare professionals in Europe agree on a standard data set they want to exchange in order to avoid the wild growth of requirements, every hospital requiring a different thing or a slightly different thing, which is very costly and also are prone for the industry to deliver. And when we can talk about, and I mentioned the ECHO project already, can agree on a specific standard where we can have most of the data we need. It's also efficient for industry to provide this for all their customers in all the countries, but also for the IT services of the hospital to link to this one interface. As I mentioned before, I also think that for Belgium, the use of a GTIN as an identifier key for other databases, like reimbursement database, also for medical devices, for implants to the RISIP's website, that this can be a driver to improve this. And therefore, I want to ask hospitals, industries, and authorities to work together from a pragmatic and risk-based patient safety point of view, rather than waiting for each other for something to happen.
Yeah. Okay. Thank you for your input. I'll look at the questions. There are some questions about EPICS posed by Yves van Hagen van Gent about EPICS. And I would say that this is not the way to exchange master data. This is meant to exchange event data. So you have a channel of through GDSN network of master data, and through EPICS, or you will exchange event data. So, but we can discuss that offline if you want further on this one. There is one up the top. Wim van den Bergen asked a question. As the UDI code is not officially linked to the data yet, it seems that Edamet will be not delivered fully functional before the end of 2023. These are all rumors, of course, and because legally there is, if you look at the legislation, it is not the case for the moment, but okay, which makes the entry of data by manufacturer only mandatory as of mid-2025. How does UZ Leuven manage to identify the devices by scanning the barcodes? Okay, Thomas, I don't know if you can answer this.
Yes, and I think it's a very good question. It illustrates what I mentioned just before we went to Q&A. The issue about the chicken and the egg and us waiting for each other. And I think when we wait for Edamet, we will never arrive where we want to go. And when I take a look at what we have in the hospital right now, nowadays, for medication, but also for medical devices, implants, we have a lot of medication and medical devices with the UDI code or with a GTIN code on it. So it's like industry is not waiting to comply with Edamet. Maybe it has to do with regulations or obligations in other countries. But to answer Wim's question, how do we work in UZ Leuven? As I mentioned, we want to scan everything and we want to do it by uniform barcode. And therefore, for implants, we want to use UDI. So what we have to do is to link the GTIN code included in the UDI. We have to link it to the article number in the pharmacy database, which is used in the hospital information system. And with this link, we can access other database, other data sets, and we can also capture the barcode in the operating theater or whatever other ward we are working with this software. Of course, this is a lot of typing work, and therefore we ask industry to provide us. And then you say you're using the wrong system. We are asking them to give lists by an Excel sheet with a link between their not their serial number, their item number, or their product number, and their GTIN codes used, so we can link this again to our database, but also in public tender dossiers, this will be a request to deliver all these GTINs and maintain all these GTINs during the duration of the contract. But I hope that when legislation, MDR, UDAMET will be in place, this will be the way to go, and we don't have to ask this anymore. But this is the way. I hope this answers your question, Wim.
Yeah. Okay. I have another question for Mark, a little bit in the same thing. Of course, in the Netherlands, there is the uniform data set has been agreed and introduced as a standard data set within the sector between hospitals and suppliers. Do you see both that this is also possible to have such a type of model in Belgium, and how should we go for it? And eventually, of course, to try to align as much to the Dutch data set to make it for international companies as beneficial as possible.
Yeah, shall I first answer? So I think indeed the Netherlands is a good example, as I mentioned, and we use the GDSN process to share data. And again, with my product manager, as you call it, Patrick, project or tool, we are working together with GS1, and GS1 is let's say facilitating this, working on a similar approach in Belgium. So to share data via GDSN, and these data are linked with the GTIN, and like Thomas said, I think this could even help to integrate this data in the hospital system to some extent, at least.
I think I have to agree, and I'm in favor of this one data set as they used in the Netherlands. And I think we should do the same thing in Belgium, but even further, I think, and that's something we already discussed with GS1 as a facilitator for this project, but also with colleagues from the Netherlands, what's in their data set, what they did agree on. And we have seen that a lot of the data are useful for us. Some aren't at this moment, but we have also seen that we are lacking some data fields we need in Belgium. And I think rather than starting a Belgian version of this data set, I think we must see in Europe whether we can add or delete from the data set and come to a mutual agreement amongst European countries, amongst European hospital pharmacists on what they need. So I think that the Dutch data set, as I've seen it, has 80% of the data we need. Maybe the 20% will not be feasible, but when we can add 10%, remember my 300 fields of data to fill, maybe I can fill only 50 by that. And I'm really in favor of a data set, but I think we must not do it on a national level, but we must see, can we use and can we extend the one we are using in the Netherlands, in Belgium, and come to a European data set.
Yeah, that's the objective, of course, of the ECHO model, where you will have the European part, but of course you will have for every country still specific fields due local regulations, and that is indeed the case. Something about the future, because some question is about the future of the introduction of the e-leaflet. Do you have any comments or any ideas on how this could go in the future?
Yeah, if you want, I can add to that. So the e-leaflet concept offers a possibility to make a digital connection to the product information leaflet, but also instructions for use, for instance, for medical device, clinical info, video material, batch information could be included. So we actually in J&J, we have run or are running a pilot in Asia now, where we basically use the GTIN and batch number can be used as well in the barcode to link to a solver via an app. We link to a GS1 solver, which I think is called a digital link. And then the solver uses the company prefix, which is actually a company-owned part of the GTIN. With the company prefix, the GS1's resolver will see that it's a J&J product and connect to the J&J solver. So then it comes to something that we manage as J&J, and we can guide, let's say, the request to the information, to a web page where the information can be tuned, let's say, to the demand of the customer. So I think this is the way forward. There are other means. There's also QR code that could be used, but we are advocating actually to use the digital link through the GTIN, because the GTIN is most of the time, and especially in Europe, it's already on the pack in a 2D matrix. So if you add a QR code, you have two, let's say, matrices on a pack. It's confusing. There's not always place on it. And basically, you don't have to change your artwork. It's already there in the GTIN. So that's an advantage. I think also the GTIN, using the GTIN provides probably more security. It's not so easy, I think, to lead you to a fake web page, let's say. But with the QR code or adjusting the QR code, I think that could be possible. And then, yeah, I think in the end, what is the advantage of having an e-leaflet besides, let's say, saving paper in the end? It also provides flexibility. If you need to change the e-leaflet, which sometimes happens when new information comes available, you can do it immediately. You change it today in your web page, and tomorrow it's available to the patient. So that creates an increased flexibility, and also you can tune it more. I mean, today you have the leaflet. Everyone knows that this is something very interesting with a lot of information, a lot of languages. Trying to find your way is not easy. With making it digital, you can create menus which would make it much more easier to select the right language, maybe the right section you're interested in, adding some videos, material, instructions, whatever. So it makes it really possible. And I see a lot of things moving over there. So yeah, it's going to change a lot in the future, this.
Okay, leaflets, very intriguing items. I think myself, it's a wonder how they fit in the package. They're very hard to read due to the small printing, the multiple languages on it. But most of all, once opened, you cannot handle them anymore. You can just throw them away. And I think it might be helpful for ambulatory patients for ambulatory patients, but in the hospital, no one uses the paper leaflet. And therefore, our professional association of hospital pharmacists supports a pilot from pharma.be on e-leaflets for medication. And we also did surveys with them, and it's shown that no one is using the leaflet, that everyone is going to an e-leaflet based on the site from the authorities, or based on a site from companies or associations. Problem with the site from the authorities is the update and the fact that it should be updated in time. But I think that an e-leaflet in the era, in the time of everyone having a smartphone or scanners, is the way to go. But of course, we have to think about older patients that are not having a smartphone. We have to provide something for them, and in the hospital we can make a print. But the benefits of an e-leaflet are legio. We save paper, of course. It's more readable to patients if they get rerouted to a readable page. But also you can add instructional videos. You can add maybe applications for patient compliance. And then again, the authorities have to follow that this is not commercial information, but really to enhance patient safety. But I think also that the structure we use in such an e-leaflet can be helpful to link to the CPOA, the electronic prescribing system, to give the physician not a leaflet as such, but only the section he needs, for instance, posology or side effects. One comment I want to make on the reaction of Dirk is the fact that he says it's on the outer pack. You have the code already, and that is useful to ambulatory patients which have a pack. But in the hospital, as we dispense per pill, again, I'm here with my request to having a single dose package with a barcode in it. And when we have a GTIN on the level below the each, I fully agree that this also can link us to an e-leaflet, and whether this is through the website you just mentioned, or that should be built, or if this is via the link, as I just explained, for the UDI and the implants from the own article database in the hospital. But I think this can be very helpful rather than distributing these paper journals.
No, thank you both. It's time. It's 12. We're already 3 minutes over, so we don't have any more time for other questions. I think we will answer them in due time. So Thomas and Dirk, really thank you to give you some input on your view on the history, on the industry, and the evolutions we are looking forward. All attendants, thank you. And if you want to see us again online, you can always go to our website and look for more information, and we are available to help you. Thank you very much, and have a nice day. Bye.
Thank you. Bye.
Bye.